Good morning. We're here at ASH, and I have with me Dr. Wee Joo Chng from the National University Cancer Institute in Singapore. One of the topics that continues to be very important and talked about a lot is the idea of MRD testing. It's been evolving over several years now, and it seems to be getting better and better, and the data sets that have been used to test these have gotten better and more robust. So has there been any particular presentation or presentations made this week that is helping to inform the community about MRD testing and the impact?
I think there are quite a number of abstracts that focuses on MRD and myeloma at this meeting. As you said, it's a very hot topic. And I think the message is very consistent actually from all these abstracts, suggesting that MRD, the ability to achieve MRD negative state, is very well correlated with a prolonged survival and improvement in PFS. And so the message is very strong that perhaps the MRD represent a very good early surrogate marker as an endpoint for clinical trials. And I think there are some movement to seek that with the FDA as an endpoint. But one particular abstract that was presented by our French colleague, Hervé Le Soul, yesterday struck me because I think in that particular presentation, there was a number of points that was very nicely illustrated by the analysis. And this is a particularly important analysis because it was done in a cohort of patients that was treated in a very well-designed randomized study that utilizes all the current key drugs that we use in the clinic. So, the RVD, induction, including transplant. So this is a very relevant cohort to us. In this particular analysis, they utilizes NGS, next generation sequencing, for MRD testing. And they have an opportunity to look in depth, what is the critical cutoff level for MRD that really makes clinical impact.
Okay.
And I think this is particularly important because there is still a heterogeneity in the way that MRD is being reported. And it is therefore important to actually, when we compare the different clinical studies, to look at what MRD level they're being reported. So in this abstract, they highlighted that really it is at a level of 10 to the power minus 6 and below where the survival and the outcome is significantly different from the other levels. And I think this is also consistent with some of the studies that were done using flow cytometry that pretty much illustrate the same, that at that level it seems to be most significant. So I think moving forward, that may become the standard level that we should be looking at MRD negative state. So that's one important point. The other important point is that because it's a randomized study between transplant and no transplant, they clearly illustrate that once you achieve MRD negative state, irregardless of the treatment arm, you have the same outcome. And this again is very consistent with some of the other reports and meta-analysis that have been done that pretty much illustrate again the same point. But I think again this provides a very powerful validation of those early signals because this is a large clinical trial cohort that is robustly recruited to the trial. So I think going forward again, when we look at treatment strategies, I think more and more studies will look at the use of MRD as a signal to perhaps de-intensify treatment. Or you could imagine a step-up approach where you would maybe use a less intensive treatment if somehow they don't achieve MRD by a certain time point, you may escalate. So, the kind of paradigm that is well established now for the treatment of chronic myelogenous leukemia may well come into play with myeloma now that we have this, what appears to be a robust interim kind of endpoints of MRD that we could then design trials to see whether we can either guide intensification or de-intensification. I think this will be a very important direction that myeloma will be heading in the future. The other thing, the third important data that came out from this particular abstract that, again, I thought is very important is that achieving MRD negative state appear to be most important in the high-risk patient.
Okay.
The percentage of patients that could achieve MRD negative state in high risk is lower, but for those that are able to achieve MRD negative, their outcome is as good as standard risk.
Okay.
So we really, when we talk about designing treatment regimes and so on for high-risk patients, we really need to look at what is the ability of these regimes to get them into MRD negative state.
So the treatment goal, if I understand you correctly, the treatment goal for any newly diagnosed myeloma patient should be an MRD negative complete remission.
Yep.
10 to the -6 is the benchmark now that differentiates survival endpoints in this regard, and that it doesn't matter how you get there, but get there. And
Yes.
It's going to vary based on access to medications, what risk stratification you fall into, and those kinds of different variables. But the treatment goal should remain, if possible, to get to that MRD negative state.
That's right. I think that's very clear from this trial. But clearly, the more active agents are going to get you a higher percentage of MRD, which means that drug access will be closely linked to the ability to get patients into this MRD negative
Right.
state. I think more importantly is indeed if high proportion of patients who are MRD negative turn out to be cured, then it becomes a very, very important discussion about how expensive drugs could be reimbursed in different countries to get patients to that state.
Just one more question about this. You mentioned next generation sequencing and flow cytometry as the two mainstays of testing for MRD. Do you see any preference happening between those two? Is there one that has an advantage over the other in terms of how it's done, or the access to the test, or the speed at which the test is done, or the consistency? What's your opinion about the techniques?
I think they both have pros and cons actually. So I think the utility and the adoption will pretty much depend on local capability and access, and maybe to some extent about the cost as well, although I don't fully understand whether there is a difference in the cost of these two techniques. But what is clear is whether you use flow or NGS, it's still the 10 to the power -6 that is the important cutoff.
Mm-hmm.
The advantage to the NGS testing is that you could use stored sample. That means your samples don't need to be fresh.
Okay.
So in terms of doing multi-center trials, the logistics of using the NGS method is clearly a bit easier,
Mm-hmm.
because you don't have to ship fresh sample all over the place to central labs. And but the disadvantage is that you do need a baseline sample as well as the remission samples for testing, because you need the baseline sample to actually see what the clones are to
Sure.
compare. The advantage of the flow is that you don't need the baseline sample. You just need the remission sample. So you can reduce the sampling that is needed. The turnaround time, I believe, will be a bit faster for the flow, because at the moment the NGS assay need to be sent to a central lab, with the turnaround. So logistically it may be a bit more challenging in that perspective. The great disadvantage of flow is that it needs fresh samples. So certainly if you don't have the local capability and you need sand, there's the issue of sampling, first of all, the purity of the sample, and then with the shipment, whether it affects viability and how that affects the readout and assay. So I think they all have pros and cons. It all depends on access and local capability. I think will depend on whether one is chosen over the other in the local site. But both are currently recognized in the IMWG response criteria for MRD testing.
That's great, and it's nice to see that there's actually now outcomes data that is supporting what we have been believing for several years now, that achieving a deep complete remission with an MRD negative status, patients should be doing better, and it seems like it's confirming that. So
Yeah.
We'll continue to track this this topic, and we'll visit with you again next year, and we can talk about it again.
Sure.
All
My
right.
pleasure. Yeah.
Thanks a lot for coming by.